I want to start with a statistic that I think most people do not fully absorb the first time they hear it. Falls are the leading cause of fatal and non-fatal injury in adults over 65 in the developed world. Not cardiovascular disease, not cancer, not stroke, falls. Every year, approximately 1 in 4 adults over 65 falls at least once. Of those who fall, a significant proportion sustain injuries serious enough to require medical attention. And of those who sustain a hip fracture, one of the most common and most serious fall-related injuries, approximately 20 to 30% will die within 12 months of the fracture. Not from the fracture itself in most cases, but from the cascade of complications that follows: the surgery, the immobility, the hospital-acquired infections, the deconditioning, the pneumonia, the decline in a body that was already carrying a significant physiological burden before the fall happened. But here is the part of the fall story that does not make it into most conversations about aging and risk. Falls do not happen randomly. They are not simply accidents that occur without warning, without precursor, without any signal in the period before they happen. In the majority of cases, the fall is preceded, often by months, sometimes by years, by a specific, measurable, observable change in the way the person walks. A change that is detectable to a trained clinical eye, that is quantifiable in a gait laboratory, and that, once you understand what to look for, is observable to a careful and attentive family member or carer without any specialized equipment at all. That change is the #1 predictor of dangerous fall risk in older adults, and it is the subject of this video. Because if you know what this change looks like, if you can see it in your parent, your spouse, yourself, you have a window in which intervention is possible, in which the trajectory can be altered, in which the fall that this change is predicting does not have to happen. That window exists, it is real, and it requires only that someone recognizes the change for what it is. Today, I am going to give you that recognition. As always, I want to begin with the biology, because the change I am going to describe only makes complete sense, the kind of sense that makes you see it differently in the people you love. Once you understand what the walking system is actually doing and what has to go wrong for it to produce this specific, observable sign. Walking, normal, healthy human bipedal gait, is one of the most neurologically sophisticated things the human body does. We do not appreciate this because we have been doing it since we were approximately 1 year old, and it feels entirely automatic and effortless. But the apparent effortlessness is the result of an extraordinarily complex orchestration of systems: neural, muscular, vestibular, visual, proprioceptive, that are operating in precise, continuous coordination. Let me walk you through what is actually happening when a healthy person takes a single step. The decision to initiate movement begins in the motor cortex, the strip of neural tissue in the frontal lobe responsible for voluntary movement. The motor cortex sends signals down the corticospinal tract to the motor neurons in the spinal cord, which activate the specific muscle groups required for the movement. The cerebellum, the cauliflower-shaped structure at the base of the brain, receives continuous, real-time feedback from the muscles, joints, and vestibular system, and uses this feedback to fine-tune the timing and force of muscle contractions, correcting errors before they produce instability. The basal ganglia, deep nuclei in the brain involved in movement initiation and automaticity, ensure that the learned, habitual components of gait execute smoothly and without requiring conscious attention for every individual step. Simultaneously, the vestibular system, the balance apparatus of the inner ear, is detecting the head's position and movement in space and sending this information to the brainstem and cerebellum, which use it to generate the compensatory postural adjustments that keep the center of mass over the base of support as it shifts with each step. The proprioceptive system, the sensory nerve endings in the muscles, tendons, and joint capsules, is continuously reporting the position and movement of every joint in the lower limb, providing the neural system with the moment-by-moment map of where each part of the body is in space. And the visual system is scanning the environment ahead, detecting obstacles, surface changes, and spatial relationships, feeding this information into the gait control system to allow anticipatory adjustments. All of this is happening simultaneously, continuously, automatically, with a speed and precision that no human engineer has successfully replicated in a bipedal robot, despite decades of effort and billions of dollars of research investment. Now, what happens when this system begins to deteriorate? The neural and physiological changes of aging affect virtually every component of this system. Processing speed in the central nervous system slows. The signals that coordinate balance and movement take longer to travel and longer to be integrated. Proprioceptive sensitivity in the feet and ankles declines. The sensory nerve endings that report foot position become less reliable, reducing the accuracy of the body's internal map of where it is in space. Vestibular function decreases. The inner ear's ability to detect head movement and position becomes less precise. Visual acuity, contrast sensitivity, and depth perception decline. Muscle strength, particularly in the lower limbs, where the quadriceps, hip abductors, and ankle plantar flexors are the primary drivers of stable gait, decreases progressively after the 5th decade, a process called sarcopenia that is driven by hormonal changes, reduced physical activity, nutritional factors, and the loss of fast-twitch motor neurons that disproportionately affects powerful, rapid muscle contractions. Any one of these changes, occurring in isolation, would be manageable. The gait control system has substantial redundancy. It can compensate for a degree of decline in one component by increasing reliance on the others. But when multiple systems are declining simultaneously, as they typically are in adults over 65, the cumulative effect exceeds the system's compensatory capacity. Gait begins to change, and the specific change it produces, the observable, measurable signature of a gait system that is operating closer to the edge of its stability margin, is what I am about to describe. The number one walking change that predicts a dangerous fall in older adults is a reduction in gait variability, combined with a widened base of support and shortened stride length, a pattern that clinicians call a cautious gait, or, in its more pronounced form, a senile gait. But the single most predictive element within this pattern, the one feature that research has most consistently identified as the strongest individual predictor of falls, is increased step-to-step variability. Let me explain what this means, because the term variability is counterintuitive. You might expect that more variable, less consistent walking would be the sign of a problem, and you would be right up to a point. But the relationship between gait variability and fall risk is not linear. It is more nuanced than that, and the nuance matters for understanding what you are looking at. In a young, healthy adult, walking is characterized by a remarkably consistent rhythm. Step length, the distance covered by each step, varies very little from one step to the next. Step timing, the duration of each step cycle, is similarly consistent. The gait has a regularity, a metronomic quality, that reflects the underlying automaticity of the system. The cerebellum and basal ganglia are running the program smoothly, making the micro-adjustments required to maintain consistency without conscious involvement. As the gait system deteriorates with age and declining neurological function, this consistency begins to break down. The step lengths become less uniform, one step slightly longer, the next slightly shorter, without a clear environmental reason for the variation. The timing becomes less regular. The rhythm that was metronomic becomes slightly uneven. This is increased step-to-step variability. And large-scale epidemiological studies, including the landmark work from the Hebrew Senior Life Institute and multiple prospective cohort studies published in journals including Gait and Posture and the Journal of the American Geriatric Society, have shown that this measure, step-to-step variability, is one of the strongest quantitative predictors of future fall risk in older adults. Stronger than walking speed alone. stronger than balance measures in isolation, stronger than many of the subjective assessments that clinicians have traditionally used to evaluate fall risk. The reason for this predictive power makes complete sense once you understand the mechanism. Increased step-to-step variability is not just a description of inconsistent walking. It is a readout of the neural control system's ability to regulate movement in real time. A high variability score reflects a system that is struggling to maintain consistency. That is, correcting more, compensating more, working harder to keep the program running than a healthy system needs to. It is the gait equivalent of a car engine that is revving unevenly, a sign that the underlying regulation is under stress, even if the car is still moving forward. And a system that is already working at or near its maximum compensatory capacity to maintain walking on a flat, familiar surface has very little reserve left for the perturbations that cause falls. The unexpected step down from a curb, the slight unevenness of a garden path, the dog that crosses the walking line unexpectedly, the momentary distraction of turning to respond to someone calling your name. These are perturbations that a healthy gait system absorbs without incident. The compensatory reserve handles them automatically. A system that is already maximally compensating to maintain baseline walking has no reserve for perturbation. And when the perturbation exceeds the available reserve, the fall happens. But I said earlier that the sign I am describing is observable to a careful and attentive family member without specialized equipment. An increased step-to-step variability, measured precisely, does require measurement. So let me translate this into what it looks like from the outside. What you actually see when you watch someone whose gait has crossed into the high-risk zone. The first thing you see is a change in walking speed. People with high fall risk walk more slowly than they used to. Not just slightly slowly, measurably, noticeably more slowly. Research has established that walking speed below approximately 1 meter per second, a pace that feels, when you observe it, distinctly slow, slower than feels natural for a person walking without a specific reason to be cautious, is associated with significantly elevated fall risk, and is, independently, one of the strongest predictors of adverse health outcomes in older adults. Walking speed is sometimes called the sixth vital sign for this reason. You can estimate it simply by watching someone cross a room. Does it feel unhurried in a comfortable way, or does it feel effortful in a slow way? The distinction, once you are looking for it, is usually apparent. The second thing you see is a shortened stride. The steps are smaller than they used to be. The person is not covering the ground with each step that they used to. This is partly a consequence of reduced hip extension, the ability to push the leg back fully behind the body, which is driven by the hip flexors and which generates stride length, and partly a consequence of reduced plantar flexion at the ankle, the powerful push-off from the ball of the foot that propels the body forward. Both of these are products of the sarcopenia that affects the hip and ankle musculature with age. The shortened stride is visible. When you watch someone who walks this way, the steps look abbreviated, tentative. The foot does not travel far forward before it lands. The third thing you see, and this is the one that most directly reflects the variability I described, is an unevenness in the rhythm. A healthy walker has a gait that has a kind of natural cadence to it, even if you cannot consciously identify it. The steps land with a regularity that the eye picks up without necessarily registering explicitly. When step-to-step variability is elevated, this regularity is disrupted. The steps are not quite evenly spaced. There is a hesitation here, a slightly larger step there, a moment of appearing to recalibrate. The gait looks, and this is the word I hear most from family members when they describe what they noticed, shuffly, or uncertain, or as though the person is navigating terrain that is more challenging than the flat floor they are actually walking on. The fourth thing you see is a widened base of support. The feet are further apart than they used to be. Rather than walking with the feet close to the midline, the way a young person walks, with each foot landing near the center line of the body, the person is walking with the feet further apart, as though bracing for instability. This is a compensatory adaptation. A wider base of support increases stability by widening the base over which the center of mass must stay, providing a larger margin before a step is required to prevent a fall. It works to a degree, but it is also a sign that the system has needed to adopt this adaptation, that the normal, narrow-based walking pattern is no longer providing sufficient stability without it. The fifth thing, and this is the one that is perhaps most telling, is the arm swing. In healthy walking, the arms swing in opposition to the legs, the left arm forward as the right leg goes forward, the right arm as the left leg goes forward. This reciprocal arm swing is not cosmetic. It plays an active role in maintaining rotational balance through the trunk and serves as a visual indicator of the symmetry and rhythm of the gait cycle. When gait is disrupted, when the control system is under stress, arm swing frequently decreases or becomes asymmetric. One arm may swing less than the other. Both arms may be held closer to the body, slightly rigid, as though the person is instinctively reducing upper body movement to simplify the stability calculation. A person walking with reduced, stiff, or asymmetric arm swing is showing you, in that arm position, a sign of the neural and postural stress that is occurring throughout the gait system. There is one additional observable sign that I want to describe specifically because it is the one that in my clinical experience is most strongly associated with imminent fall risk and is most consistently underappreciated by the people watching. It is the hesitation at transitions. Transitions in gait are the moments of highest instability, the moments when the gait system is most challenged and when the fall risk is highest. These transitions include initiating walking from a standing start, turning, changing direction while walking, navigating a doorway or narrow passage, stepping over a threshold, beginning to walk on a different surface, from carpet to tile, from flat to slightly sloping, stopping and starting while doing something else simultaneously, walking while talking, walking while carrying something, walking while searching for something in a bag or pocket. A person with a high-risk gait hesitates at these transitions in a way that a healthy walker does not. They pause before initiating. They slow significantly before a turn, sometimes stopping and executing the turn in small, shuffling steps rather than the smooth, continuous arc of a healthy turning gait. They look down at thresholds and step over them with exaggerated care. They stop walking when they need to do something else that requires cognitive attention, answering a question, looking for something, navigating a conversation, because the cognitive demands of walking and the cognitive demands of the other task are competing for resources that are no longer sufficient for both. This last point, the cessation of walking when a cognitively demanding task is added, has a clinical name. It is called the stops walking when talking sign, and it is one of the most clinically robust predictors of fall risk identified in the literature. Research published in The Lancet showed that older adults who stopped walking when asked a question during a walking assessment were significantly more likely to fall in the following year than those who continued walking. The reason is exactly what the mechanism I described would predict. In a person with a gait system operating at or near its compensatory limit, the addition of a cognitive demand that competes for neural resources, even a simple conversational demand, tips the system over the edge of its capacity to simultaneously maintain safe walking. The system responds by dropping one task, walking, to devote resources to the other. It is adaptive in the immediate sense, but it is also a direct readout of the lack of reserve that makes this person vulnerable to a fall from any perturbation that does not give them the option of simply stopping. I want to tell you about a patient I will call Frances. Frances was 78 when her son brought her to see me. He had not brought her because she had fallen. She had not fallen, not yet. He had brought her because of something he had noticed over the preceding several months and could not entirely articulate but could not dismiss. He said, "She walks differently. I cannot explain exactly how. She walks differently than she did 2 years ago, and it worries me." When I asked him to be more specific, he said, and I am paraphrasing but closely, "She takes smaller steps. She goes more slowly. She sometimes stops when I ask her something, and when she turns around, she does it in a way that looks careful, like she is thinking about it. Frances, when I spoke to her, minimized the observations. She felt fine, she said. She was a little slower than she used to be, perhaps, but that was natural at her age. I asked her to walk down the corridor and back. What I saw was a gait that had all 5 of the features I have described. Slow speed, well below 1 meter per second. Shortened stride, the steps barely clearing the length of her own foot. Widened base, feet noticeably further apart than normal. Reduced arm swing, arms held close, movement minimal. And at the turn, a pause, a slight reorganization, a series of small shuffle steps to complete the direction change rather than a smooth, continuous arc. When I asked her a question mid-walk on the return, something simple, her address, she stopped, answered the question, then resumed walking. Her timed up and go test, a standardized assessment in which the patient stands from a chair, walks 3 meters, turns, walks back, and sits, took 19 seconds. Normal for her age group is under 12. High fall risk begins at 12. 19 seconds placed her in a category that, without intervention, was associated in population studies with a falls rate of over 60% in the following year. She had no idea. She felt fine. She had told herself this was aging. We referred her to a falls prevention physiotherapy program. We reviewed her medications. She was on 3 that have known associations with fall risk, including a long-acting benzodiazepine for sleep that she had been on for 4 years, and that I consider one of the most dangerous medications a frail older adult can be taking from a falls perspective. We arranged a home safety assessment. We had a detailed conversation about the specific transitions that represent the highest risk moments in her daily environment. Getting up from her favorite low chair, the step from the back door into the garden, the bathroom floor when wet. 18 months later, Frances has not fallen. She completed the physiotherapy program and has continued the balance and strength exercises independently. The benzodiazepine was gradually tapered and discontinued. Her timed up and go at her most recent assessment was 15 seconds, still above the normal range, but meaningfully improved from 19. She walks with more confidence. Her son notices the difference. She is not restored to the gait of 60, but she is substantially safer than she was, and she has not fallen. Let me now give you the practical framework. What to do if you recognize the signs I have described in a parent, a spouse, yourself. The first step is to ask your GP or primary care physician for a falls risk assessment. This should include a timed up and go test, the standardized assessment I described, and ideally a more comprehensive gait and balance evaluation. If your surgery has access to a falls prevention clinic, ask for a referral. Falls prevention is one of the most evidence-based areas of geriatric medicine, with interventions that have robust trial data behind them. It is also one of the most underutilized, because the patients who need it most are often the ones least likely to proactively seek it. The second step is medication review. This is, in my clinical opinion, one of the most high-yield interventions available for falls risk in older adults. A significant proportion of the gait changes I have described are partially driven or significantly worsened by medications. The classes most commonly associated with falls risk are benzodiazepines and non-benzodiazepine hypnotics, the sleeping tablets, which impair balance, slow reaction time, and reduce muscle coordination. Anticholinergic medications, which include many antihistamines, some antidepressants, some bladder medications, and some anti-nausea drugs, impair the central nervous system processing that underpins balance and gait. Alpha blockers and other antihypertensives can cause orthostatic hypotension, a drop in blood pressure on standing that produces dizziness and instability. Diuretics can cause dehydration and electrolyte disturbances that affect muscle function and neural regulation of balance. Any medication that causes dizziness, sedation, or impaired coordination is a falls risk medication and warrants specific discussion with your prescribing clinician about whether the benefit continues to outweigh the risk. The third step is targeted exercise. The evidence for specific exercise interventions in reducing falls risk is among the strongest in preventive medicine. Balance training, exercises that challenge the balance system by reducing the base of support, altering sensory inputs, or adding movement to unstable positions, has been shown in multiple randomized trials to reduce falls risk significantly. Strength training, particularly targeting the quadriceps, hip abductors, and ankle plantar flexors, the muscle groups most directly involved in gait stability, reduces the sarcopenic weakness that contributes to shortened stride and reduced gait speed. The Otago Exercise Program, a home-based program of balance and strength exercises specifically designed for older adults, has been shown to reduce falls by approximately 35% in community-dwelling older adults over 12 months. Tai Chi, which combines balance training, slow, controlled movement, and postural awareness, has robust evidence for falls reduction, specifically in older adults. These are not gentle stretching routines. They are targeted, progressive interventions that work through specific biomechanical and neurological mechanisms. The fourth step is home environment assessment. The majority of falls in older adults occur in the home. The bathroom, particularly on wet floors and around the toilet and bath, is the highest risk location. The bedroom, particularly at night in reduced lighting, when the gait system is at its most vulnerable due to the effects of sleep inertia and the disorientation of waking in darkness, is the second highest. Stairs are third. A home safety assessment conducted by an occupational therapist can identify and remediate specific environmental risks: the loose rug, the inadequate lighting, the absence of grab rails, the low chair that requires maximum effort to rise from, that interact with the gait vulnerabilities I have described to produce falls. The cost of these modifications is trivial compared to the cost, financial, physical, and human, of the fall they prevent. There is one more thing I want to say before I close, and it is the thing that is hardest to say, but the most important. The gait changes I have described, the slowing, the shortened stride, the hesitation, the variability, are not invisible to the person experiencing them. They are felt. The person who is walking this way knows at some level that something has changed. They feel the uncertainty. They feel the extra effort. They feel the moments of instability that they manage, quietly and privately, without telling anyone. They feel the fear, and it is often fear, though they may not name it as such, that keeps them sitting down more, declining more, contracting the perimeter of their life to match the energy and stability they feel they can reliably offer. And very frequently, they do not tell anyone, because naming it makes it real, because they do not want to worry their family, because they have absorbed the cultural message that this is what aging looks like, and there is nothing to be done. There is something to be done. The research on this is clear and consistent. Falls are not inevitable. Gait deterioration is not inevitable. The trajectory that ends in a hip fracture and a cascade of complications is not the only trajectory available. But changing it requires that someone notices, names, and acts on the sign that the trajectory is heading that way. You may be that someone for a person you love. Watch how they walk. Watch how they turn. Watch what happens when you ask them a question mid-stride. Watch the arm swing, the stride length, the hesitation at the door threshold. And if what you see matches what I have described today, do not file it under getting older and move on. File it under something I need to act on, and then act. If this video gave you something you needed, a framework for something you have been watching and not quite understanding, please share it with someone who also needs it. Leave a comment telling me what you noticed. And if you have been through a fall with a parent or yourself, and you are on the other side of that experience, I would be grateful to hear what the early signs were looking back. I am Dr. Julian Cross. Walk carefully, and I will see you in the next one.